Good evening. This is LeezFeed Podcast. I'm your host, Lee Coleman, and today we have Mr. Dr. Jeffrey Sterling as our guest, and he's the chairman of the Health Committee for the Illinois State Black Chamber, who sponsors this podcast. Larry D. Ivory is the president and CEO. He's also the chairman of the board for the National Black Chamber of Commerce. Having said that, welcome aboard to our podcast, Dr. Sterling.
Pleasure to be with you.
Yes, sir. A lot of people may or may not know you. This video is going to go on YouTube with your permission. And we'd like to just get a quick bio. Who is Dr. Sterling, Jeffrey Sterling?
I'm a physician. I was born and trained at Cook County Hospital. Of course, now it's Stroger, but back in the day, Cook County, where so many people from a certain era, a certain generation were born. I trained as an emergency physician. I'm a public health professional, having trained at Harvard back in '91, and have used that to migrate from taking care of patients individually for 25 years to taking care of communities, and have done so around the world on 5 continents and 38 states inside the United States. I am also a business person and a healthcare entrepreneur. I run several businesses, including a consulting and implementation firm and a medical supply firm, both of which are global. And I also run a physician staffing company that provides physicians for various emergency departments in different hospitals across the country. And I am president and CEO of SIMCO, which is America's first preventive care organization that is really looking to change the face of healthcare and change the pendulum away from what we call curative care toward health prevention and health promotion. So I have a lot of hats that I wear, and basically I'm building a healthcare universe, all with the desired end result of eradicating healthcare disparities and health inequities. So that's just a little bit about myself. And I would be remiss if I didn't point out that I'm also the Surgeon General for Alpha Phi Alpha Fraternity Incorporated.
Okay, you mentioned 2 types of health modalities. Could you go over that again?
Health modalities?
Yeah, you mentioned 2 different types of an approach for health. Yes.
Yeah. So basically, if you are building a healthcare system, and I always point out that the United States doesn't have a healthcare system, it has a healthcare industry, which is a pertinent conversation for an entity like the Illinois Black Chamber of Commerce. We in the United States tend to enter, as individuals, we tend to enter the healthcare system at the point in time in which disease presents. So the half of the conversation that begins when you engage your medical home or your physician or an emergency department is called curative care. An easier way to think about it is sick care, the actual treating of people and diseases. That approach is not unique in the United States, but it is very much emphasized in the United States. And, you know, I have to tell you, it is a big part of the reason why the United States has what's ranked as the 37th best healthcare system in the world, even though it spends much more, about 17% of its gross domestic product. 1 of every $6 spent in the United States is spent on healthcare, and that's $3 trillion, far more than any other healthcare system in the world. The next closest is actually France, which only spends about 11% of a much smaller gross domestic product on healthcare. A typical country will spend about 4% of its gross domestic product on healthcare. And again, if we're 37th, you might immediately be thinking, well, hell, how do the other 36 countries actually produce better healthcare outcomes? And that's the second modality that you alluded to, and that's health prevention and health promotion. But we all learned this way back when, right? An ounce of prevention is worth a pound of cure. And it's really just that simple. So instead of waiting for people to get sick and then engaging them at that point in time, the modality which SIMCO, and I've promoted for decades through Sterling initiatives, tries to get people to be healthy and stay healthy so they don't have to get healthy. Where we talk about being better stewards of your own healthcare, engaging in the simple things such as diet and activity and taking immunizations as is appropriate to be in front of the game so that when the opportunity for disease comes knocking at your door, you are able to defend it. You know, just to give you a quick example, this thing with COVID was very much an illustration of this concept. The very people that continue to die with COVID are people that haven't engaged in preventive strategies. They aren't vaccinated, or early on, the people that were dying for COVID were those individuals who were either obese, elderly, or otherwise immunocompromised. Because there's not a cure, if you wait until the point in time in which disease presents, you will not have as good of an outcome as you would if you stayed healthy and had a strong immune system and was able to fight it off. Too many of us are born with certain types of deficiencies that we can't help. And I'm not trying to demonize them at all, but for those of us for which a certain lifestyle that isn't promoting health is an option, then it's really unfortunate that so much of the disease that exists, particularly in African-American communities, is actually preventable. And to the extent to which it is, we want to change the conversations and transform people from a sick/curative care frame of mind over to health prevention and health promotion. I'd much rather our community be defined by healthy lifestyles instead of healthcare disparities and always being sick from the things that present.
A couple of things grabbed me in your conversation. One is that, well, three really, I don't want to forget the three. One was that as I progressed in my employment through certain state agencies and municipalities, the insurance did not cover the preventative part. They did not cover physicals, which was a preventative. We know what you see on TV all the time. Hey, you know, get ahead of your, you know, go get a colonoscopy, go get this checked out, that checked out. But when you went to your doctor, they say, hey, guess what? Your insurance doesn't cover physicals. One thing. The other thing was, do you want to say anything about that? Have you found that to be true in this system also?
Well, I want to moderate your comments because I really hope that's not true. Many of the managed care organizations,
Now,
formal name of insurance companies, actually will tell you that they have a plethora of preventive health offerings. What I would say is that those offerings are not emphasized, not promoted, and not taken advantage of. And they certainly aren't built out and developed in a way that is appropriate and empowers us to live a lifestyle based on health prevention. Too much of the incentives for these entities, again, it's an industry. You get paid more in this system for doing things to people instead of talking with people, from engaging in procedures and surgeries and treating sick care instead of teaching people, spending time talking to people about health prevention and health promotion. So that much, I will go that far, but without specifically looking at any individual data or insurance companies. You know, you can infer that, but I'm not prepared to totally endorse that.
I understand. I was just saying that was my experience.
Yes, that's fair.
Right. Another thing, I do believe in preventative care. I'm a proponent of that. But as a nearly 70-year-old man, I've had not one doctor to talk to me about exercising and eating the right foods.
That's not true.
No, I'm saying to me.
You have one talking to you today. I'm joking with you. Obviously, I'm talking to you about it now, but the point that you're making is the correct one. We as a medical community simply spend too much time dealing with sick care. And that's the point. It's really a very simple point. I'm an emergency physician. You have to remember, at the point in time in which you see me, the opportunity for these things is long past. And I'm trying to save your life, if that's appropriate. And it's because of all the lives that I've had to save and have lost. It's just a much simpler course of action to actually go way back and let's just try to reset how we actually approach health and healthcare in the United States.
Absolutely. And then now getting to the vaccines. In the old days, we took our shots for the different types of diseases. The vaccines were attenuated vaccines. And now we have mRNA. What do you think about the difference in that? We know that the attenuated vaccines worked, polio, smallpox, and other childhood diseases, we took those shots and they've been effective for quite some time. Now we have mRNA. So some people are having a problem with that because of the warp speed that the mRNA was developed. And I think we had the infrastructure. I know we had the infrastructure already in place for the attenuated vaccine, which has been proven effective over the years. Now we've got mRNA, and there's some hesitancy on a lot of people's part about that because now they're talking about a booster. First, the CDC said, no, we don't need a booster. The same companies that they gave emergency use authorization to put 160 million shots in people's arms in this country, those same companies came back and said, guess what? We think we're going to need a booster because we don't think that that vaccine is going to last more than 5 to 6 months. And the CDC publicly and the FDA publicly said, no, we don't need that. Now they're saying, okay, comorbidities, maybe so. But then it just went today and said, in September, everyone who's had 2 shots can get the booster. So saying that people are dragging their feet with reference to getting vaccines, doesn't the CDC and the medical professions hold some guilt with reference to confusing the hell out of us?
Man, you just dropped a whole lot. So I'm going to dissect what you said. So the first part of what you said, you know the difference between disinformation and misinformation? Disinformation is the intentional provision of wrong facts, okay? It's propaganda about these things. Misinformation doesn't come with judgment attached to it. It's just the sharing of information that's actually wrong. Okay. Now, again, unless you are a subject matter expert in public health, medicine, or science, I don't really expect you to understand these matters. And again, I actually appreciate the fact that you're asking questions instead of being one of the folks that would presume that they have all the answers and have all this figured out. So let me just take a second, and we're going to deal with the first half of what you said, which included quite a bit of misinformation. So let me break that down for you. People who watch this don't even know what attenuated vaccines are. So by the time I get done with you, this is going to take about 4 or 5 minutes. You're going to be feeling pretty good about this.
Okay.
So it is absolutely true that there was a thing once upon a time called live, you left that word out, live attenuated virus vaccines. What that means is that way back in the day, we actually took a piece of a virus, a live virus,
Absolutely.
and gave it to you. And this, no, I'm not talking to you, I'm talking to your audience.
Okay.
So right now, we're talking, remember folks, we're talking about practice. I'm going to do an Allen Iverson on you. All of this is about practice. So once upon a time, we actually gave people live viruses. That's what live attenuated viruses are. And your body responded to just a bit of the virus as practice. And then when a big bolus of the virus came through later, you were able to fight it off. We migrated from live attenuated viruses to what was called inactive viruses. So instead of a live virus, the next thing we did was we chopped off the actual organism and took off the part that actually stimulated an immune response. So we gave you a particle, a piece of what had been a live virus. That was the next part of the evolution of this. So we gave you that, and your body responded and said, oops, I know you're part of a virus, I'm going to attack. So that subsequently, if you actually saw a live virus inside of you, you had practice and you were able to fight it off. The next generation of evolution of vaccines was synthetic particles. So instead of giving you anything that came from an actual virus, scientists developed a methodology by which we would take something that approximated a particle from a live virus. Okay, so this now we're not even in phase 3, we're not even giving you anything from a virus anymore. We're just synthetically making something that looks like something that plugs into a receptor and stimulates an antibody response. You with me?
Yes, sir.
Phase 4 is where we are now. Messenger RNA is simply slipping you a note. It's like a fax that disappears in 72 hours. So what is it? Snapchat is one of these systems that exists where you send a message and then it disappears. Mm-hmm. We're not even given a particle, a synthetic particle that represents a virus anymore. Messenger RNA is kind of like a carrier pigeon. It is literally giving your body a cheat sheet. instructions on how to build antibodies for the vaccine that is yet to come. All right, so that's what the messenger is. It's teaching, giving your body a cheat sheet so it can practice and fight off a virus when it comes later, right? So the second part of what you said is absolutely incorrect, is that this is new. This is not new. The messenger RNA technology has been around for about 20 years.
Okay, 20 years,
It just,
70 years, okay.
It just has not been applied.
Great.
It just so happened that in the face of a pandemic, the world's scientists said, let's just look at all the tools that we have here lying around and see what we can apply to this particular pandemic and see if it works. And as luck would have it, the messenger RNA methodology actually worked. So it's not that scientists were able to create something inside of 12 months and it was rushed. It's something that was already on the shelf, that was pulled off on the shelf, that had been worked on for 20 years, was able to be dealt with. And furthermore, the even more important point about this is that this happened efficiently. Let's stop saying quick. The world's scientists and researchers did something that has never been done before. So if you're talking about time by itself is a false metric. You don't care about time, you care about metrics such as safety and efficacy, effectiveness.
Mm-hmm.
And instead of one scientist working on something like, we have vaccines that typically take 12 years when you have one lab based on the pharmaceutical company that's studying very slowly year after year after year.
Let me stop you right there. Let me stop you right there for a second.
Okay. Let me make a point, then I'll come back to you. Hold on.
Okay.
Instead of one research lab doing things for years at a time, you've had the entirety of the world scientific community collaborating and doing different parts of research all at the same time. So much so that this is now among the most researched vaccines in human history. It just didn't occur over 13 years by one lab. It occurred by bunches of labs all over the world. So this actually is framed in the scientific community as a fantastic success, something that has been done incredibly efficiently, because we're in the middle of a pandemic. Why would you, in the midst of a pandemic, expect us to wait a dozen years to come up with a solution? That's crazy. That's not what happened here, and it's actually a good thing. Back to you.
Okay, so I understood everything you said. I guess one of the things I would think about was the fact that we knew, based on scientific research and in the past, the history of it, that we know, like Obama said, and I think 16 or 14, that it's not if the next pandemic is coming, it's when. And he created this pool of scientists to do just what you just said, to study these different viruses and potential pandemics that would come. And we never in the history of this country, you correct me, you're a doctor, have we ever thrown as much money into the research to create or be prepared for the next pandemic as we did with COVID? If you look at it over a period of years, have we actually done something like that, put the money there so that we can be prepared? And even though it might take time to develop certain vaccines, we could have been ahead of this curve had we devoted the money into the knowledge that we already had. And then the anticipation, knowing that the next pandemic was coming, we would be ahead of the game.
No, I mean, of course not, because look, there are two reasons why the answer to that is of course not. Number one, this country is not going to throw that kind of money at something that doesn't exist, because again, we focus on sick care. We don't spend our days engaged in health prevention and health promotion. So it was actually a pretty phenomenal thing for the former president to be forward looking enough to say, let's put together a task force and actually study some things so that we can be prepared for the next pandemic. The scientific community was able to project. We didn't know what it was going to be, but we're able to project that something was going to happen. And it was just very forward thinking to be able to say, let's actually do some research and put it on the shelf so that we can have new methodologies in the event something like this happened. And that's exactly how this went down. It's an incredible success. And to frame it in terms of it was being rushed, it was sinister, it was a cash grab, you should be thankful, the royal you, not you individually, we should be thankful that that level of foresight and preparation was in place, because instead of 625,000 deaths, we will be dealing with tens of millions of deaths. So this actually is a pretty good thing. And remembering that all, the Delta variant came out of India, the initial variant came out of China. This isn't some conspiracy that came out of the United States. These are things that happen across the world. And whether it came from a bat or came from animal to human transmission, whatever the case would be, it behooves us to be prepared. Like I said, stay ready so you don't have to get ready. We would have been slaughtered much more so than we had been had we not had those things that were being put in place previously.
Okay, last question on COVID. Do you think that the vaccine hesitancy has anything to do with the mixed messages coming from the CDC, the administrations, Trump's and Biden's, and the fact that it was back and forth, no mask, wear the mask, you can take the mask off after you've had 2 vaccine shots, and you can do just about anything you want to do. Now it's back to mask. We're only going to get 2 shots. Now they're talking about a booster. Do you think that the administrations, Trump's and Biden's, and the panel of people that were simple, Burks, Fauci, and these other guys, do you think they bear some responsibility in the confusion and the hesitancy on many people now, about 90 million, that says, I don't know what to do. I don't think I trust this thing.
So what? I mean, again, even if it's not our fault, it's still our responsibility. You're talking to a guy that is all about, I spend all day, every day, trying to figure out how I can empower us to be better stewards of our own healthcare. I am spending my time trying to be a trusted messenger. We do have to know where we can go to get accurate information. Really what this is the public is not, you're not a scientist. People who are Dr. Google and Dr. Facebook and all the rest of that, you don't understand how this process unfolds. So what you are describing is the ebb and flow of the scientific method. This happens with every disease that ever comes out. It just has never happened before in full view of the public. I have no expectation that the public would have understood that at one period of time, the data would have said you don't need to wear a mask. And then 2 weeks later, based on new data that came out, that would have been reversed. That's actually how this works. And if you talk to physicians, and if you've actually paid any attention to what physicians, scientists, and public health professionals have been saying, we have always equivocated our comments. We go wherever the data tells us to go. And that can be frustrating to the lay population who just wants answers. But if the data says today, if the preponderance of data, we don't go back and forth based on an individual research study, but if the preponderance of data says one thing at one point in time, recommendations are going to be based on that. And if the preponderance of data switches, then that's where we are. And unfortunately, what you had is a lot of people who were believing that the majority of people who got vaccinated would create something called herd immunity, and then they wouldn't have to do anything and everything would work out for itself. That part of the messaging was absolutely horrible. So I'll give you that one all day, every day. The messaging to communities of color in particular was not being led by what I describe as trusted messengers, okay? Because again, we have issues and we deserve our issues because the medical, scientific, and research communities have not been kind to African Americans historically. And so our hesitancy to some extent was justified, or even if it wasn't justified, it was understandable. But what I want you to appreciate is that we can't afford to be wrong. Okay, we can't afford to have that hesitancy when our communities, and just to use Chicago as one example, when you have a city like Chicago in which the death rate amongst Blacks is twice that of whites, we can't afford to be hesitant. We should have been fighting for our place in line instead of talking about Tuskegee and Henrietta Lacks and all the rest of that, because at the end of the day, while we're hesitant, everybody else is jumping to the front of the line and taking our spots. And at the end of the day, vaccine hesitancy isn't what's going to kill us. The virus is what's going to kill us. And as long as we go unprotected, and that means that we weren't having access to masks, and ultimately we weren't first in line to get vaccines when we should have been, that was the biggest fly in the ointment. The biggest misinformation was us being told in total, yeah, your vaccine hesitancy is justified because of Tuskegee and Henrietta Lacks, neither of which had anything to do with this. We should have been telling our communities, we should have been empowered and put in a position to tell our communities, forget what you heard, forget what you know. I'm on this wall as a result of people like you and a generation older than me who fought to have physicians, scientists, and public health professionals on that wall, because if all this stuff that people were concerned about was true, then I'd be the one from the rooftops yelling, stay away, stay away. But what happened is that you have people like me actually trying to be trusted messengers telling us, this isn't that, folks. You got to get to the front of the line. Look at the data. We're the ones that are being slaughtered by this. And we weren't being put in positions and empowered to get to our people in a way that could have assuaged some of the fears. So the challenge is, yeah, the government did what governments do. And there's plenty of fault and blame and all of that. But ultimately, what I'm about is health prevention, promotion, and empowering communities and empowering us as individuals to be better stewards of our own healthcare. What I wanted to see happen was for us and our communities to get enough and sufficient information so that we could say, look, folks, regardless of what recommendations are coming down from the federal government, CDC, FDA, all the rest of that, the data is different for our communities. Our communities need to stay the course with masking, social distancing. We need to be fighting to get to the front of the line. At the same time that the elderly and the immunocompromised were being given special considerations, African Americans should have been fighting to get special considerations, because according to the data, we were dying upwards of 40% of everybody else. So that's what we've missed out in this conversation. We have to have more trusted messengers that are in positions to talk to us and not just rely on entities that have historically betrayed us and that we might not be able to trust. Because until that happens, yeah, we're going to have vaccine hesitancy, and I'm not going to blame anybody for having legitimate concerns. I just don't want folks to have irrational fears. And in order to migrate from one to the other, we need to be empowered with data and facts that are coming from trusted messengers.
Okay, appreciate that. That's a very powerful and important information. Let's jump to the chamber. What was your interest in joining the chamber?
Making a difference. I mean,
Sure.
again, look, like minds think alike, and I think that if you look at where success has come from, both in terms of empowering and representing the interests of Black businesses in the state of Illinois and even nationally, you got to go where the rubber meets the road. And you know this as well as I do. The chamber has a long legacy of success and actual accomplishments in delivering business to Black businesses. And even though we are historically, there's economic disparities and sometimes outright discrimination in how we are treated, as best as I can tell, the chamber is out there on the front lines in a way in which no other organization is able to or has done. So in as much as healthcare is an industry, here's what I tell people. If the United States is spending $3 trillion, not billion, $3 trillion a year on healthcare, there needs to be some Black in it. And people think, when you think of healthcare, you think of a doctor taking care of a patient. No, there is an entire economic industry in which that money is flowing from business to business. And until we have a understanding of that, President Nari certainly, bought it in total. When these are things that I do all around the world. So my impressing upon him that it's not just construction, it's not just technology. Healthcare is this nation's biggest industry, excluding what it does with the military. And you cannot let the largest industry, excluding the military in the United States, go without having that infrastructure in place. So, he accepted the challenge, and we've been building opportunities for members and those that are interested to participate in what the state does, which is spend $19 billion a year on its state Medicaid offerings and work with corporations and other entities who engage in healthcare spend as well. So it's just a very important thing. And it is something that if there's going to be a chamber, this needs to be a part of the conversation. And if there's going to be a state government that's spending money on healthcare, we need to bring it to their attention that there needs to be diversity, inclusion, and ultimately equity in how that spend is occurring.
Okay, if I'm saying this right, under the heading of healthcare as an industry, what are some of the industries that are, part of the healthcare system? What are some of the
I mean, just think about it. Let's just say that you have business X. Okay, so we tend to, as I mentioned, you tend to think of healthcare businesses as things like hospitals and home health facilities and physicians' offices, things that actually provide services to patients. And that's one huge sector of healthcare. But there are also other things because, once again, what about the ancillary entities? What about those businesses? Who is providing them with accounting services and legal services and IT services? So there are peripheral entities that are very much involved in the businesses that practice healthcare. But what about the consultants who design strategies and engage in best practices? Healthcare consulting is a huge, part of the industry. And then there are other peripheral things that involve health outside of medicine. There's a nail salon and a beauty salon on every corner. These things promote health. There are other offices outside of what we would call mainstream medical care. There's chiropractors and acupuncturists and many other individuals, testosterone centers and other things that are off the beaten path, if you will, but are more and more becoming mainstream in how healthcare is being offered. So all of these different things represent ways in which your healthcare dollars are being spent. And we are looking out across the landscape toward businesses that not just practice health and medical care, but interface with healthcare systems. So for example, if you have a $5 billion managed care organization, who's providing their legal services? Who's providing their IT services? Those dollars can be given to BEP certified Black businesses. And we should be looking at all businesses in the healthcare space, not just as it relates to how can I help you provide healthcare, but how can I help you spend money that allows you to proportionately allow us to participate in this industry. So we have lifted all of that into consciousness, and we are looking to both engage majority business as well as minority businesses and state governments, understanding that there are opportunities and we have capacity to perform across the board in all of these levels. Okay. It's a very important way that we've grown the health industry group committee inside of the chamber.
So you're saying we do have capacity to compete?
Oh, absolutely. But again, this is another very important part of the conversation. The capacity question is something that's been used to historically
absolutely
promote institutional discrimination.
Right.
Some people say racism. Racism is a judgment. You can actually prove with data that discrimination has occurred. So as these things go, that's a distinction without a difference. At the end of the day, an entity like the chamber cares about whether or not the dollars are being spent. You don't have to like me, but if you spend the money, we're going to be okay because that's going to help us. But the point that I want to get across is that the system as it currently exists only promotes and institutionalizes a second-class citizenship for Black businesses. So all these contracts, and just think about this for a second. Isn't it curious that the BEP system in total only talks about subcontracting? It provides opportunities for us to participate. And we're supposed to go to all these entities that are primes and established and beg them for certain proportions. Now again, just use healthcare for an example. If there's $19 billion being spent in state Medicaid, they have gotten waivers such that 80% of that money gets lopped off the top because, oh, that's medical care. That's not applicable to BEP spend. So somehow they've gotten away with taking 80% of the money off the top. And that leaves $3.8 billion. And then out of that $3.8 billion, 20% of that money, actually the legislature just increased it to 30%. Historically, it's been 20% of that money is called administrative spend. 20% of the administrative spend is supposed to be the target for diversity companies. So now you went down from 19 billion down to 3.8 billion to 20% of that number, which is only 760 million. And that's what the goal is in healthcare, $760 million out of 19 billion. And, oh, by the way, the diversity spend in the BEP program isn't just Black, isn't just Hispanic, but it's been amended further to include white women. And as luck would have it, they're not even close to making that $760 million. In a good year, they'll do about 100 million. So let's just say we went from 19 billion, and now we're all the way down to about $100 million is actually being spent in total on diversity communities, inclusive of white women. But then, no, there's more. Even amongst that spend, guess how much of that number is going to white women as proxy for diversity communities? Over 50%. So now out of $19 billion, this system is only offering upwards of about $50 million a year to Black and brown businesses across the state. Now, if that's not perpetration of structural discrimination, some might call it racism, I don't know what is. And year after year, when they come and say, hey, we increased our spend this year by 30%, they're expecting applause. But again, if I had 1 penny and next year you gave me 2 pennies, that's 100% increase. And that's the problem that we're faced with. This notion at the beginning of the conversation represents structural and institutional discrimination. We will never achieve equity by chasing these pennies that are being partitioned off for BEP participation. If you're actually going to get past diversity and inclusion and get to equity, you actually need to look at the entirety of the infrastructure on which these systems exist.
That's the question.
So one more point. You can't talk about just how to promote BEP participation as subcontractors. There is a total absence of conversations as to how to get BEP contractors across a bridge that would allow them to become a prime contractor. And that's the biggest challenge that's in front of us. And that is the work that we're doing in the Illinois State Black Chamber of Commerce Health Industry Group. We're actually looking at how to build that bridge and promote generational wealth, because the path that has historically been taken will continue to perpetrate this subcontractor status where we're only getting a very small piece of a very small piece of a very small piece of a pie.
So these dollars that we're talking about, the 19 billion, is this total state
Billion.
funds, or is billion? I mean, is this totally state funds, or are they commingled with federal funds?
No, okay, so this is a little bit of nuance. There's a difference between Medicare and Medicaid. Medicare is the federal program that provides support mostly for the elderly, but for other individuals who qualify. So you care for the elderly, that's what Medicare is. You aid the poor. So Medicaid is more of a program that helps people who can't afford to otherwise be insured. And you aid children, so it's typically for kids. So that's what Medicaid represents. That program is a partnership between the federal government and individual states. So the states don't have to contribute to Medicare, but they have to contribute to Medicaid. And in the state of Illinois, the contribution towards state Medicaid is $19 billion a year.
My question was, again, in that 19 billion, federal funds are commingled there. There are some federal funds.
Medicaid. No.
No,
Yes.
state.
No. But yeah, but the state's portion of the spend is 19 billion. There are additional funds that come through from the federal government.
Okay. Okay. Under the Code of Federal Regulations, which governs federal spending, they have provisions for set-asides and quota. Those are two crazy words that people don't like to talk about. So is this a case for the underutilized versus the overutilized groups to look into a case of set-asides, or use the word quota, but set-asides? There are provisions in federal government for set-asides and quota when there's egregious proof of discrimination.
Yeah, that's not a winning debate. I can tell you, having spoken to many legislators, set-asides and participation in the economics of healthcare spend is not even close to being prioritized when you are dealing with the provision of care to a community. The argument that wins is, how do we better provide services to all citizens of any given state, and to in doing so, provide better alternatives to the state. But believe me when I tell you, there is no, and we've had these conversations, no one is walking around carrying banners that say the BEP spend is horrible, we must reverse this. Now there's a BEP council inside of CMS, Central Management Services, that is supposed to be reviewing and overseeing these considerations. But in terms of legislation or initiatives being carried out by legislators, they hold these entities accountable, and there's contractual language to hold folks accountable for their BEP spend, but there is no initiative and not necessarily an appetite that I've been able to see for righting the wrongs of historic underrepresentation and underparticipation of minority and diversity.
That's something that needs to be looked at. I mean, there's a pathway to it legally, and if we're not getting it done any other way, and I beg to differ, if I understood you that they're holding their feet to the fire, the legislators are. I mean,
No. What I'm saying is that there's a mechanism for them to hold the feet to the fire. I don't think that anybody can actually say that there are any examples of having called anyone to task for their failures year after year after year. No, let's get that clear. I'm not even close to saying that. Okay. I'm one of these businesses that actually is here trying to conduct business. And I can tell you this, I told you, I've done work on 5 continents and 38 states. And I'm very careful when I say this, but I'm going to say it because it's true. This situation that we are confronted with in our home state here is the hardest business climate that I have confronted anywhere in the world.
Wow, that's saying something.
It really is. But we're going to win this fight, and we're going to correct things because the citizens of our great state deserve the type of culturally sensitive and culturally specific services that we can offer. Healthcare outcomes, simply put, this is a public health dictate. Better public health, better healthcare outcomes are produced when they are produced not by socially, culturally sensitive entities, but by culturally specific entities. But that's another way of saying FUBU. I am going to do a better job with my organization. Think about this for a second. Here's another thing I'm going to go out on a limb. I would bet that my organization can produce better healthcare outcomes for our community than entities like the University of Chicago, University of Illinois. Because again, go back to what you said before about who has responsibility in all of these things in terms of getting information out. You need trusted messengers. You need people that look like you, that walk the walk and live like you, to be able to engage and show. This isn't about being in an ivory tower or an academic institution and coming up with what you think will work. This is us living this life, knowing what embodies and defines our culture, and then moving that into our communities and transforming our communities to adapt a different path, a better path. These are things that only we can do. And unless we're given the opportunity to do these things for ourselves, we'll continue to get so much of what we've historically gotten, which is healthcare disparities and healthcare inequities.
Okay, well, we're going to close here. That was a very, very thorough presentation there, Dr. Sterling. Really appreciate that. And I'm also thankful that the Chamber has sponsored this segment. Larry D. Avery is the president and CEO of the Illinois State Black Chamber. And you are the chairman of the Health Care Committee. Am I right about that?
That's correct.
Okay, what is the functions there for you with reference to that committee, Chair?
To find opportunities for member businesses. We have well over 100 businesses that are part of the health industry group. And we spend all of our time trying to find opportunities for those businesses and using the services of various parts of the health industry group to come together and to increase capacity. There's a new concept that we're championing. We talk about every year at Kwanzaa, right? Cooperative and collaborative economics. We are actually looking at putting different companies, Black businesses together to jointly apply for different contracts, whether it's from the state or from private business. And we're doing that as a means of increasing our capacity, increasing opportunities, getting us to a point to where we have the experience and the management of different grant sizes to then be positioned to apply for future opportunities as primes. And that's what the Simcoe solution, my business Simcoe, is all about. We're working with over 100 Black businesses through the chamber and otherwise to build capacity to go into communities and engage in this transformational health prevention and promotion project. And you've heard a lot about that, and you'll continue to hear a lot about that. But the idea is that, I am because we are, and we actually have more capacity and more opportunities to be successful, not just in getting contracts, but in implementing contracts if the sum total of many of our businesses come together and engage opportunities and challenges where they exist.
Okay. Again, thank you for that informative presentation. And we look forward to talking to you again, Dr. Sterling. If you ever have a need to come on this program, let us know. You have our contact information. And that was, like I said, we need to hear things like what you've presented tonight. So thank you again for joining us on LeezFeed. And we look forward to hearing from you again, sir. Thank you so much.
All right. Thank you for what you do, and always pleasure working with you. Be well.
Yes, sir. Take care. All right.